So we're going to go backwards. We're going to start at the very beginning. And I'm going to be talking about pregnancy dating and the elements of first trimester losses. I have no disclosures. Keep your eyes on my screen and not the syllabus, because there are many more slides in the syllabus and it'll frustrate you tremendously. Our objectives today are for you to be able to distinguish the sonographic sequence of normal early embryologic development. Remember, the pregnancy is an embryo before 10 weeks gestation. I want you to recognize early anatomy and placental implantation. I want you to know and to be able to justify the definitive criteria for an early pregnancy loss. And then hopefully we'll get to identifying retained products of conception after an early loss. So we all know that establishing an accurate due date is crucial for obstetrical care. And about 2% of pregnancies in the United States are IVF pregnancies, and your ART, your assisted reproductive technology dates, are going to be your most accurate. Usually your patient will know. But if they don't, chase them down, because it's definitely worth the information. If you don't have that, expect variation. We all know that last menstrual period is really fraught with difficulties. Did I really start bleeding? When was my spotting? When was heavy flow? Maybe it wasn't 4 weeks before. We have subjective recall bias. We tend to remember the 10th day of the month and the 15th day of the month. All that adds to our confusion. Furthermore, we were taught, ovulation usually comes on day 14. Actually, in ongoing pregnancies, it's typically day 16, and you can see that there's wide variation. Maybe your high school bio teacher told you that those sperm can live in the vagina for a week. So again, timed intercourse can't really help you that much. What about fertilization to implantation? There's a variation in when that fertilized egg will implant into the uterus, and the median day of implantation is like day 27. Yeah, we're here for an ultrasound course, so we do crown rump lengths, right? But when we do crown rump lengths, the variation is 5 to 7 days, but we don't take really into account the difference in growth between implantation and when we first see them, let alone that there are a whole bunch of different normograms that we can use to date a pregnancy. So we're stuck with variation. But we're here doing ultrasound, so let's talk about the early ultrasound landmarks. The progression of sonographic findings is reproducible and it's predictable. Firstly, the fertilized egg implants itself into the deciduous slightly eccentrically, and you see this little hypoechoic fluid collection with an echogenic rim that's slightly to the side of the endometrial echo here. At 5.5 weeks, you see the yolk sac. And at 6 weeks, you see the little tiny embryo, and that's when we first start seeing embryonic cardiac activity. And by 7 to 8 weeks, we'll see the amnion around the embryo, and we'll start seeing those little limb buds.
So I'm going to now talk about genetic evaluation of fetal anomalies with a focus on first trimester stuff. And I've talked, yesterday about screening and about diagnostic testing, and I'm going to review some of that a little bit, talk about how to choose the best test, and talk a little bit about exome sequencing, which is really where anomaly evaluation is going, and I'll try to make it not too detailed genetics-y, but really sort of understandable of what that test can do, because it really is a phenomenal addition to our armamentarium of genetic testing. So I'm going to talk about the different kinds of genomic variation, how we use different genetic tests, and then, as I said, talk a little bit about exome sequencing. So, as I said yesterday, I talked about screening and how in the past we screened really with a real focus on chromosome abnormalities, and now the world has become much more complicated. We certainly screen for those, including copy number variants, which are very small chromosome abnormalities, as well as now more single gene disorders, which are the cause of many of the fetal anomalies that we see, and then diagnostic testing has to reflect those screening tests. So there is not, at this point in time, a one-size-fits-all test for everything. It's really looking at this menu of options and thinking about what's the best test to do in a given situation, and it is complicated. So the main types of genetic variation that we can see that can cause fetal anomalies are whole chromosome abnormalities like Down syndrome, and we can test for those with a karyotype or FISH testing, or in Europe they use something called QF-PCR, but those all look for whole chromosome abnormalities. Again, Down syndrome, which we used to really focus on, now there's many, many other things that we can test for. And then microdeletion syndromes like DeGeorge syndrome, 22q deletion, and those things you need a microarray for. And then there's single gene disorders like cystic fibrosis and Tay-Sachs disease and those kind of things, which are just a single base pair change. And those you can test for with single gene testing or panels or exome sequencing, but a microarray will tell you Down syndrome, but otherwise you have to do both of these at the moment. You can't test for everything with just one test. Once we're doing genome sequencing, we will be able, that can do everything, but that's still $10,000 and not really available clinically. So typically we start with thinking about the chromosomes and do maybe a karyotype or just a microarray, and then go on to exome sequencing. But as it turns out, the yield of exome is so much higher than microarray that I think that's going to change, and that may not be the best approach, sequential approach to take. It just ends up taking a long time.
During this presentation, I'm going to share with you some cases, and I assembled cases primarily in pregnancy, diagnosed in the first trimester, about adnexal masses, to give you some perspectives and some clues along the way of how do you evaluate those cases. If you have not downloaded this free online educational resource, I would suggest that you do so and share with your sonographers and residents. It's available from this website, openultrasound.com, and it's translated in many languages. And some of the information that I will share with you today is obtained from the book. So, first, characteristics. I'm going to go through characteristics of common adnexal masses, and then I'll show you some examples, and we'll kind of discuss how to address those. So, ovarian hemorrhagic cyst, or hemorrhagic corpus luteum sometimes called, is a characteristic picture like this, where you have this thin, lacy reticular pattern. This is when the clot is filling the whole cyst. There's excellent sound transmission, excellent capsule seen all the way around, no obstruction of structures below. Over time, if you follow this patient, the clot retracts, and you have a fluid solid level within. And this is a different patient with a clot. What I'm showing you here, if you gently probe this, you see how it moves like jello, it jiggles. Another important characteristic that's really relevant is when the clot retracts, it typically retracts to one center. So you don't have any other nodules along the way, and the borders are typically very smooth, as you see right here. Unlike cancer or borderline tumors, where they could be multifoci and the borders are ragged. Borderline and malignant tumors, and I'm going to show you a bunch of those. Again, you see the borders, there's papillary projections typically associated with that. They could have thick septations, as you see right here. The papillary projections tend to be multi-centered. You'll have one or two or three sites. The borders are ragged, as you see here. And low velocity color Doppler will actually show you flow within those, most of the time within those papillary projections. Again, if you see right here, there's irregular borders to this. There are multiple foci, and this was a borderline tumor. So was this one.